I'm Sari Cooper, a certified sex therapist and sex coach in New York City. I'll be your host to Sex Esteem, a new show where we will explore in all its expressions relationships and sex in the modern world. Tune in for fun-filled facts and entertaining tips to having a more pleasurable sex life. I'm so excited today because we finally found time to meet Dr. Rachel Rubin. Let me give you a little info about Dr. Rubin. She's a board-certified urologist with fellowship training in sexual medicine. She's an assistant clinical professor in urology at Georgetown University, and she owns her own private practice in Washington, D.C. She provides comprehensive care to both men and women. She treats issues such as pelvic pain, menopause, erectile dysfunction, and low libido. And she's currently the educational chair doing an incredible job for the International Society for the Study of Women's Sexual Health, otherwise known as ISWISH, and an associate editor for the journal Sexual Medicine Reviews. And she was named a Washingtonian top doctor in 2019 to 2022 and has been on the Zero Medical Advisory Board since 2018. And Dr. Rubin and I met at the SMSNA, Sexual Health Medicine Society of North America. I probably said it differently.
Perfect.
And we saw each other last year and we saw each other this year. And it's been like a dream for me to sit down and talk with you. So welcome.
Oh, I'm so happy to be here. And gosh, I'm sorry it took us so long to connect. That's all on me.
Well, so I wanted to start because I think one of the things that you've been best known for, especially in the last year, is sort of, shouting from the rooftops that medical professionals have not been trained in sexual health medicine, right? And I think I feel like an affinity with you because I think when I became aware and trained and certified as a sex therapist, I thought, oh my God, like, why did I not get any of this training when I was getting trained as a couples therapist and a social worker, right? So, and I did the same thing. I was like, we got to get more people even aware, maybe not trained, but even aware enough to know when to make a referral. So tell us about that sort of journey for you.
Yeah, it's exactly the same analogy, actually, right? Is everyone would assume that couples therapists talk about sex and know how to talk about sex and can talk about the nitty gritty, because how can you be a couples therapist and not a sex therapist, right? It just seems so obvious. And yet many couples therapists don't even touch sexual health with a 10-foot pole, as you will admit to, and say that that is true, which is mind-blowing for me as a doctor. Like, I wouldn't have ever thought that. Similarly, right, patients think their gynecologist knows everything about women's sexual health and their urologist knows everything about men's sexual health. And it's also not true, right? Is the idea of there are subspecialties of doctors and clinicians who really care about sexual medicine. And I wish like more kinds of doctors should know about sexual medicine, because sexual health is just health and it does not just about the genitals, right? Like, it's kind of important that your cardiologist or your neurologist or your cancer doctor knows about sexual health and how any of their treatments, surgeries, therapies, medicines are affecting your sexual health. But we have no training on it. There is no standard training about sexual medicine in gynecology. In urology is a little better, but it's still not great on the female side. And so we have so much work to do to shout that out. So I have a big job and you have a big job. Is not only do we have a lot more to learn within our fields because there's so much unknown, right? So we have to do the research. We have to learn more. We have to ask the questions because we're seeing these patients every single day. We have to then teach the other clinicians why it's important and how to do it. And then you have to see patients and actually do the work because not a lot of people are actually doing the work. So I'm pulled in a lot of different directions because I so deeply care about all of those avenues. And so if we don't expand this work for more people doing that, because it's not just enough for people to be like, oh, that's so interesting. I'm so glad Sari's doing sex therapy, but that's not, that's great that she's doing it. But we have to get other people to want to do it and to do it well, because I think there's more people now who are interested and kind of curious, but not a lot of people who are really doing this at a high, really intellectual level. And honestly, it does take more than a quick 10-minute visit to do a good job at this, which is what makes it kind of challenging.
Right. And I think the other thing I would say to you is that I was trained as a couples therapist using family systems theory. And family systems theory means not just that we're seeing the partners in the room together, which is very much a factor, but I was trained as a social worker as well. And that we believe that we have to all be working together with other professionals. So I need a good sort of list and team of urologists, gynecologists, cardiologists, psychiatrists, right? And we all have to be talking together about whatever case that I'm working on, because if we're all in our little silos, which I do think the medical professional sort of does just automatically because of lack of time and also lack of training, that we're doing a disservice to these clients. And I wanted to jump in because I know your time is limited, and I wanted to talk about pain. And one of the things that like just blew my mind, I don't know, I've been in practice 25 years. I started becoming a specialist 15 years ago. And one of the things that blew my mind was the young women coming into my office talking about the pain upon penetration at young ages in their 20s that they've been enduring for years. And I was like, oh my God, like what is going on here? So can we talk about that? Because I know we'll get into a whole lot of other stuff that you're talking about, but I wanted to start with
and to tie
women.
that in is I think that those people actually, what gets them better the fastest is a team approach, right? It's usually not just one magic switch that I turn and everything's better, but they really do need a biopsychosocial approach, which means we have to involve our mental health professionals, because when you have pain from the first tampon you put in, or for 10 years, every time you try to get in a relationship or be sexual, that will really mess up your brain. And so it is not in your head. Please don't ever let anyone tell you that pain, for like penetrative pain, is in your head, because it almost is never. It's in your head. It definitely does a number to your head, but it is not in your head. And so there are really biological reasons behind why sex is painful, but that doesn't negate the fact that mental health is really, really important for these patients. So there are many, many reasons why penetration could be painful, but the three most common reasons: number one is a hormone imbalance or a hormone change. So the vulva and the genitals are very hormone sensitive. And I always say, when you play with hormones, there are consequences, sometimes good and sometimes bad. So a lot of young people are put on birth control pills, which can alter the genital sensation and how the genitals feel. And so that area at the opening of the genitals, called the vulvar vestibule, is exquisitely sensitive to changes in hormones. So birth control pills, while it can be good for acne and preventing pregnancy, can actually, in some people, hurt this lining, this vulvar vestibule lining at the opening of the genitals, which can then lead to the second most common reason we see this problem is pelvic floor muscle tightness. So if the tissue hurts, or if there's a lot of pelvic pain, the muscles get really tight and they really kind of tense up. Like some people hold muscle tension in their shoulders. You're working all day, you feel the knots. A lot of people of all genders feel it in their pelvises. And so their pelvic floors are really tight. So those symptoms can be pain with sex, but it can also just be constipation. It can be urinary urgency, urinary frequency, and lots of things can cause pelvic floor tension or tightness. Not just, stress and trauma and anxiety can certainly lead to tightness, but also things like back problems can lead to tension in the pelvic floor. So we see even if a hormone problem can increase the risk of tension in the pelvic floor. So there's lots of things that can cause tightness in the pelvic floor. And we love working with pelvic floor physical therapists, because they also are kind of detectives who can really help us understand, why are these muscles so tight? A, how do we get them to relax? And B, where's it coming from, right? Where else is it coming from? So, and
wait, before you get to the third one,
yeah.
I want to add, yes, pelvic floor physical therapists are a specialized trained kind of physical therapist. So they can go in there and they can actually do like acupressure to find out where you're holding tension. And I want to say another thing is that you will not necessarily know that you're holding tension in your muscles in the muscle tone of your pelvic floor. And that becomes like a huge surprise when women go and men, by the way, get examined by a pelvic floor physical therapist. Now, number 3.
Men. Yeah. And number 3, which is less common, but we do see it. And these are people who are either born or develop sort of a nerve proliferation in the tissue at the opening of the genitals in that vulvar vestibule. And that is the patient who the very first tampon that went in, they can't tolerate any speculum. It is everything is so painful. And so it's really important that you see a doctor who understands these problems, because again, the general gynecologist and the general urologist and the general primary care doctor has no training in this. And so it is really important to see a specialist. And so ISWISH, that organization you talked about, and you can find a provider at isswsh.org. You can encourage your provider to go to an ISWISH training course, because I think we can all learn new things. We can teach people how to do new things. And so they never learn this. So unfortunately, like, think of yourself, if you have one of these problems, as needing to go to a super specialist, right? People will travel to go to the Cleveland Clinic or Mayo Clinic because they have some rare disease. Now, vulvar pain and pelvic pain is not rare, but the teaching of people to doctors of how to treat it is rare. And so you do have to seek a specialist in this case, and sometimes see multiple opinions, because that's the other problem, is that some of us have a lot of different opinions. And so you have to kind of be a detective yourself to figure out what makes sense. Is this a hormone problem, a muscle problem, a nerve problem? Sometimes people have all 3 or 2 out of 3. Sometimes there's a whole body diagnosis. We see people who have connective tissue disorders, and they can have a lot of these issues. So there's more of whole body issues that can be involved. So you want to see someone, many of us, I wish I had a magic switch for all of these patients and they see me one time and boom, they're better. But sometimes it takes detective work and, really kind of trying to figure things out. And so you need a team that's going to be there with you to really help support you.
And so what I think I want to just highlight of what Dr. Rubin is saying is that there's got to also be agency, that you have to trust your instincts. Don't, I can't tell you how many women come into my office and they say, well, I did go see a urologist, or I did go see a gynecologist, and they said I'm fine, or they said my levels are fine. And I would just say, well, I'll say, well, let me ask you. So when they examined you, first, did they examine you? And then secondly, when they examined you, did they do a Q-tip test of the vestibule? And they'll say, what are you talking about?
Right.
And
what's a vestibule?
Right,
yeah.
Right. And so what's a vestibule? Why are they using a Q-tip? And explaining how, the vestibule can be looked at as a clock. They take they do a palpation. That's when someone is looking for something. They know what to look for, right?
So it's really, we want our doctors to know everything. We want our doctors, the one doctor, to be all knowing in baby making, in genital problems, in breast cancer. Like, we want them to have all the answers, and they don't. And it's real. And sometimes they think they do, and they also don't. Right. And so that's really important. That's why for my patients, I give them everything I can find for them to read and learn. I want them to follow my colleagues on social media. I want them to ask questions. I want them to go dig into the research themselves. I have a bad habit. I get my patients becoming really advocates, right? They start going and creating organizations, and they start marching because they're angry, and I want to turn their anger into actual change. So we have a great organization that we work with called Tight-Lipped, which is a whole patient advocacy organization of people with vulvovaginal pain and pelvic pain conditions. They are not playing around anymore. It is a group of patients who are going door to door to residency programs to say, we will teach you how to examine vulvas ourselves, because no one else is doing it. And so I'm one of their medical advisors, and I'm here cheering along the way, because that's what's going to cause real change. So they have a really cool, everyone should donate to them, but also should go on their website. They're doing petitions to the White House. They're doing petitions to GYN residency programs. So again, use that agency to say, this happened to me. We're not going to let it happen to other people.
And I think implicit in what you're saying is money, right? Because there aren't enough studies on women's sexual health. And in order to actually affect change, we need money, we need awareness, right? The other thing I want to bring up today is whenever someone has had like pain for any length of time, no matter what stage of their relationship, whether they're just dating, early stage relationship, or if they're perimenopausal and they've been partnered for a while, or maybe they're single and they're perimenopausal and they're out there trying to date, but like feeling like, what am I going to do? Because it's going to hurt again, right? The issue is that it's a partner, it's a relational thing, and women haven't been taught how to talk about their own health to a partner, to take care of themselves, to say, you know what, I would like to just focus on outer course. When I say that word outer course, people look at me like I have two heads, explaining that, there's so much sexual pleasure you can get without penetration while you're working or seeking to work on the pain problem that you've had for a long time. So let me ask you something. Like when people ask you, like, okay, but how am I going to talk to my husband or partner or, about this? Like, what do you say?
Well, I often tell them, right, so I think sex therapy is a great option, right? We can all learn how to communicate about this better. I like to biologicalize it, right? When people understand the biology, they can talk about it so much more easily than this magic sex unicorn thing that's kind of hard to talk about. But what they can say is, hey, this area right here, this pelvic part, it looks like a sunburn, feels like a sunburn. Look what I learned today. I'll have patients bring their partners to visits, and I can even show them, like, look, it hurts here, but a millimeter over, it doesn't hurt. She's not crazy. Like, look at this. It actually hurts. It's so wonderful for the partners to get involved, because then they really get it. They get that this is no different than high blood pressure, cancer, or diabetes, right? That's a medical problem, which has medical solutions, but also understanding that there's lots of good ways to have sex. When these partners were in middle school, nobody was dying because they weren't getting penetration, right? This idea that orgasm, pleasure, connection, intimacy, it can look a lot of different ways. And so it's in a way, some of my pain patients actually have way better sex than the patients who don't have pain, because they're thinking outside the box. And I mean that pun very intentionally, right? They're thinking outside the box, and they're talking about it. They're adventuring. They're using their words. They're bringing in devices. And so when we get the pain that go away, oh my gosh, like then there's another tool in the toolbox. And it's so good. It can be so good. So I think that's really the key there.
Right. And so the other thing that I wanted to stress is that when we're talking about outer course with women, with straight women, is that they're more likely to have an orgasm with external stimulation. And we know that there's an orgasm gap between women and men, heterosexual women and men. And that part of it is that there isn't enough time spent on outer course or out of the box playfulness, right? And so going back to the basics of let's explore one another is so important. And it takes this pressure off this penetration thing, which, by the way, is what people will call normal sex, right? But I'm not doing normals. I'm not doing sex. And I think we have to like free people, liberate people to understand that sex is a whole umbrella, right? That they can have enjoyment through. So when you have people who are older, let's talk about that quickly, because you've been talking a lot about, we were talking about contraceptives, but now we're talking about hormones in perimenopause and menopause, and why, people of that age aren't getting the care that they need, right? Because a whole history is there, right?
Yeah, so this is where it's the same problem. It's the same location. It's the same issue. When you play with hormones, there are consequences. And in menopause, there are a lot of consequences of losing hormones in your body. The genitals are very hormone sensitive structures. The bladder is a very hormone sensitive structure. And when it doesn't have hormones in the vagina or in the bladder, you are at much higher risk of urinary tract infections, which can kill you. And you get your urinary frequency and urinary urgency. You get vaginal dryness. You get pain with sex. And all of that is because of a loss of estrogen and testosterone to the tissue. And so there are very safe, very effective local hormones, either vaginal estrogen or vaginal DHEA, which are FDA approved and safe for just about everybody. There is really nobody on earth who I wouldn't recommend vaginal hormones for. And I'm talking breast cancer patients and patients with blood clot history and patients who've been told they can never touch estrogen. everyone can be on vaginal hormones, which are local, low dose, and prevent urinary tract infections by more than half. And so it's really important that people in their 70s, 80s, and 90s realize that their urinary symptoms and their urinary tract infections are absolutely due to menopause and can absolutely be treated and cured. I'm very serious about this. And so I think a lot of people are dying and being hospitalized unnecessarily because they're not being taught that this is a hormonal problem. And unfortunately, we as a society call this problem, ooh, a little vaginal dryness, right? Ooh, I'll just stop having sex, or I'll just add some lubricant. And it's very serious. It's not just a little vaginal dryness, but it is urinary tract infections and really severe problems that can really hurt you long term.
Right. And the other thing that happens though at this stage, right? I talk to people about what stage of the relationship they're in. At that stage though, there are other complications and layers, right? So there, Dr. Rubin's talking about the biological medical issue, but on top of it, you may be in a relationship that you're not happy in. You may be in a relationship where you're kind of bored with the sex that you had. So like, why? You may come in and they talk to me about, well, I have no libido, right? I have low libido. Well, if you have pain upon penetration, you're not going to feel like having sex, right? But the other thing is, I think that women, especially, and the research shows this, is that women rely on novelty. Most women need novelty in order for their erotic mind to become much more turned on. And if you've had the same if you think about diet, if you've had the same thing for lunch every day for 20 years, right? You're going, I don't want to eat it anymore, right? So you have to actually bring in some new novel escapades, right, with your partner, and your partner has to understand why that's important, right? It's not just the biological, it's the, psychosocial part as well, and the sexual inspiration, I want to say.
Again, biopsychosocial, that's the key to just living the funnest life ever for as long as possible. We all want to be Dolly Parton at 78, right? That's the exactly, that's the goal.
Right. So there's a new, I think it's fairly new, YouTube. Well, you can follow Dr. Rubin on Instagram, right?
Yeah, Instagram, Twitter, Facebook, YouTube. It's Dr. Dr. Rachel Rubin. We'd love to have you join when in whatever phase of life you are in. We are really just trying to give good information to people.
And I think you also did a recording recently, which I was watching, which was amazing, like really going into detail about the use of hormones and how important it is and why it doesn't cause cancer, right? And why it has been proven through the research that it's safe and healthy for most patients, right?
It's so the local hormones to prevent urinary tract infections are legitimately safe for everybody. And anyone who tells you differently is really working based on 30-year-ago data that really was never right in the first place. When it comes to whole body hormone therapy and menopause, to help hot flashes, night sweats, to prevent osteoporosis, and to help with your sexual health, again, you want to see someone who is up to date on the real data, because the way we used to do hormones 30 years ago is not how we do hormones today. And the safety profile is so much different than it was 30 years ago. And so it's really important that you have educated conversations with a clinician who knows how to have educated conversations. And so if this is the same person who delivered your baby and who has no interest in menopause, and you get 10 minutes and they brush you off and dismiss you, that is not the right person for you to be working with. So you want to see either someone from ISWSH, ISSWSH.org, or someone from the Menopause Society, which is menopause.org. They have Find a Provider. I'm on both those lists, right? If you're in the area, in the Washington, D.C. area, but you really want to see someone who actually will sit down and customize it for you, because your risk for taking hormones is completely different than even your sister's risk or your neighbor's risk. And so you deserve individualized care to figure out what are the pros and the cons, the risks, the benefits, and what do you want for your quality of life? What are your goals? I think too often people just say, well, my doctor said I can't do this, and so I'll just sit here and suffer and complain. And so it's really, again, that agency. The more you can educate yourself and gather information, then you can go to your clinicians and say, oh, listen, I've done the reading. I don't think you're actually right about this data, and actually push, because a lot of times you know more than they do, which is very sad and depressing, but true.
Right. And in the same way, I would say if your couples therapist is telling you that the reason why you're feeling pain is because your partner betrayed you through infidelity, or because you have family of origin issues, or because you have sexual trauma only, you have to reach out to a sex therapist, because a sex therapist is trained to work as a team with urologists, gynecologists, people who are well trained. And we will not just assume that the pain is all here. Okay.
Oh,
So
thank you
that's
for
on you.
existing. Thank you for existing. That's so good.
All right. So thank you so much. I know you have to go,
Thank
and
you
I
for having
really
me.
appreciate you being here. Thank you.